Hi, everybody. Welcome to our lecture for week one. We're going to cover the several chapters that we have. And what I want you to know is that I will share these PowerPoints with you as well. It's chapter 1, 2, 3, 9, and 23. So when we start, we look at our chapter 1, and it's really going to be talking to us about community nursing and what that is. I want you guys to know there's two different kinds that we're going to talk about. It'll be community-based nursing, which is going to focus on illness care of individuals and families across the lifespan, and our growing costs that we see with hospital care. More nurses are engaging in community-based nursing because the focus is going to be on illness care of individuals. But we also do have community-oriented nursing, which is going to focus on promoting quality of life, healthcare of entire individuals. And our goal there is going to be prevention. So we're going to try to prevent our disease and illness among our population. It's going to include public health nursing. It's going to, again, with our oriented, we're going to be promoting a quality of life and not so much about the illness care. We take a look at public health because this is the bulk of what we're going to be seeing in community. Public health, is a scientific discipline that includes the study of epidemiology, which is how things work and why, our statistics and assessment, including attention to behavioral, cultural, and economic factors, as well as program planning and policy development. So when we look at that, we're going to see our benefits with working with public health. We're going to have an increase in life expectancy, and so a decrease in early mortality is a decreased number of death and stroke from coronary disease and strokes. And among our adults and our children, population-focused public health is going to prevent for up to 70% of our early deaths in America as compared with only 10%. Know that we look at Public Health and Affordable Care Act of 2010, which changed the way that we did health promotion and prevention to focus more on community-oriented approaches for wellness, and we look at reducing the incidence and burdens of the leading cause of death and mortality. So think about how the benefits the United States might see if more money was given to public health policy, and this is something that's in politics as we speak today. We take a look at our three functions of our public health. We have assessment, policy development, and assurance. Remember, our assessment is our systematic data collection on the population, monitoring our health status and making information available. Then we do our policy development, where we create policies that will help the health of the population. And then we have our assurance, which makes sure that our community-oriented health services are available, making sure we have personal health services for individuals as well as workforces. We have a pyramid when we look at our healthcare system, and we know that we have population-based is on the bottom, then we have clinical, primary, secondary, and tertiary. Now, primary is going to be our level where everyone's relatively healthy. We're trying to prevent disease process. Secondary, we are going to be doing our screenings. We're going to be looking for those disease processes to minimize the side effects. And then our tertiary, we're going to have those that are already have a condition, and how can we work to limit those side effects of it. So think about with our essential services of public health, we diagnose and investigate problems, we inform, we educate, we develop policies and plans that are going to help. And so when we're thinking about public health, we're thinking of the whole group of people. We need to look at research and see how that helps. Now with our population focused nursing practice, we have three different areas we look at. Our population, which is who are we looking at and what do they share with their characteristics. Then we'll have subsets. So we'll have groups of people in our population that all have similarities. For example, what we see here is those above 65. And then population-focused practice, we have problems that are defined in solutions, policy development, preventative services, and things like that to help with diagnosing and treating at the individual level. So we go from a large group of people to a smaller group to each an individual person when we're doing our population-focused nursing practice. We know we talked about community-focused, community-oriented interventions at the community and population level. So what are some things that we do in the community? We'll do things like mammogram vans, we'll do blood draws, things like that. Like with our COVID vaccine, we had clinics set up where you could just drive through and get your vaccine. And so that was trying to help all the people as a whole. And when we look at public health nursing, we know the nurse often reaches out to those who might benefit. So we're going to reach out to our older, our vulnerable clients as well. So we look at our two types of practice focus in, we talked about community-oriented, and we talked about community-based, which really focuses on individuals and families. So when we're looking at that population focus, it's going to be serving individuals rather than a population. Developmental screening tests, emphasizing health protection and promotion is going to be with our families and our group focuses. So we look at all the kids in Head Start to evaluate if the problem is working. So you can see here it's more population focus is more specific, and this is going to be general with a larger group of people. We have the community nursing models that we talked about. Community-based is going to be where we're managing acute and chronic conditions, focuses on our illness care of individuals. So we'll give acute and chronic illness care, and we have a setting practice where the people will live and work. So with our community-oriented, we're going to have prevention of disease and disability. So we're going to focus on healthcare of individuals, families, and groups. What are some challenges that we're seeing and concerned about for our future with our public health nursing? Trend to move care into community settings and reduce the number of hospital days for sick clients. We know in the hospitals we have guidelines that we need to follow, so we're trying to make sure that that becomes community care is less expensive. It's not going to spend as much for our insurance companies, and our trend is expected to grow. And with the role in the nurse in the community will continue to change. So that about covers our introduction, our chapter 1. We're going to take a look now at our chapter 2, and we will look at the history and dynamics that have gone on in public health nursing. So if we look at our history, we really know the reason we look at history within public health is because one of the best ways to understand what worked or what didn't work will help us guide us for going forward. So we take a look at early public health. All people and cultures have been concerned with the events surrounding birth, death, and illness. We know ancient Babylons understood the need for hygiene, some medical stuff. Egyptians, we saw a variety of pharmaceutical preparation. They did a public drainage system. And then we have our Elizabethan poor law, which is in 1601. And then our Industrial Revolution. Remember, we have to create nursing homes and facilities during that period. So during the colonial period, at first it was a family friend system, but this came insufficient. We couldn't really care for each other as family and friends. So we established systems that cared for the sick, the poor, the mentally ill, and dependent based on the Elizabethan Poor Law in 1601, which guaranteed medical care for our poor, our blind, and individuals who needed that. So we take a look at that as we moved along. In 1751, we had a first hospital founded in the Pennsylvania Hospital in Philadelphia. We had epidemics that came along in our 17th, 18th, and 19th century, such as those with smallpox, yellow fever, typhoid, and typhus. And then we had our public health system, 1798, which helped to focus and protect cities from epidemics. Public health system was established in 1798 at the Marine Hospital Center. So we look at also our nurses that we know. Remember Florence Nightingale, about 1894 to 1946, she organized care for patients, realizing that the poor, the not good conditions that they were living in was causing more and more illnesses. We see that the first nursing school opened based on Florence Nightingale's beliefs in 1870. Then we had our VNA that started with Lillian Wald and the Henry Street Settlement in 1893. And know that we had neighbors and neighborhoods facilities that were established during this time and to treat those that needed it. And we continued on. We have some other origins of training: American Red Cross, occupational health nursing, which was started 1895. We had school nursing with Lena Rogers. So when we take a look at our public health nursing and how it's grown over the time, all the way back to the 1800s, we see Public Health Association established. In 1909, we have our continuing nurses program. 1910, we're looking to infectious disease and parasites. And then we look at leadership beginning in nursing in 1920 and 1930. Well, in public health nursing also, we saw a large part of this. World War I, we saw the need for public health nurses to stay in the United States so they could care for our military people. In 1918, we had the influenza pandemic, and knowing that we worked with that and got hospitals with huge numbers of those dying from the flu, and that helped look at us. In 1909, we know the Metropolitan Life Insurance Company create a program letting visiting nurses provide care for sick. In 1921, we had the Maternity and Infancy Act, also called the Shepherd-Towner Act. This act provided funding for mother and child health division, the state departments, and it was an important big piece there. Then we had the Frontier Nursing Service, 1925, which was founded by Mary Breckinridge. She introduced the first nurse wives in the United States, and she had them in public health and midwifery. We see reductions in pregnancy complications and mortality, and infant deaths decreasing. So interesting with our Frontier Nursing Service in 1925. Some challenges we've seen is segregated nursing in the South until the 60s. National Health Center for Colored People in 1919. We do see there some scholarships that were created to try to minimize that. We had an economic depression and the effect on public health. 1930 depression, we saw agencies and communities unable to meet needs and numbers of the poor, decreasing funding for nursing service, Social Security Act. We have World War II in the 1970s, and origin and progression of COVID-19 is another one we saw with public health. In 2019, we saw the introduction of it with Wuhan and the Chinese government. In 2020, we see the Chinese government closed a new virus had been detected, and then we see how World Health Organization declared the virus a pandemic. And so when we look to the future, we're going to look to see that nurses are going to seek from the past and avoid pitfalls that they know has come. As plans for the future are made, we need to know what our vision of nurses can accomplish. And so many things we can see with our COVID pandemic is one that's most recent. So that about is our history and our background with our chapter 2 and our history of public health. We're going to continue on here, and we will take a look at our chapter 3, which is going to include a little bit about evidence-based practice and our global and domestic needs and challenges. So when you think about this chapter, we want to think long and hard about the changes we've seen in the U.S. We know that population growth is huge. Our baby boomer generation is huge, is increasing, very large. We are changing the composition of the U.S. households. Know that we have very different types of households than we've ever had. We have same gender, different gender, married, not married, things like that. Our largest minority group, Hispanic persons, now outnumber our African Americans as our largest group. We know that we've seen a decrease in mortality. We see more infectious diseases emerging, like we saw with COVID. New treatments for infectious disease have resulted in declines in mortality, and older age groups are more likely to be exposed to those things. So we want to think about that. Our changing lifestyles. So we want to think about how we now look to take care of ourselves. We know our shift has changed to the importance of financial successes, rising national income, average per house income is increasing. And we take a look at our health workforce trends, knowing that we have our reduced bed capacity. If anyone has heard in the news, just with the outbreak of COVID and RSV and all that, we saw a reduced bed capacity. So we have to do things more in the community. Expanded services are going to be including our mental health and substance abuse. Many hospitals really saw this diminish of bed capacity and nursing shortage during our COVID. 27% of RNs are planning to retire. And many of them are baby boomers. And so we know that by 2026, we're going to have several new nursing opportunities out there. We know there's not enough healthcare providers right now. And so we look at our advanced practice nurses to fill in on that. But the thing with that is sometimes they have to work under a provider, and sometimes that's difficult to do. And know that we had in 2020, minority nurses represent about 31% of our population. So we want to look to increase that number. When we look at our technology trends, we know that technology has improved greatly. We do telehealth. We have reduced costs, meaning people can get care over the computer. It's more convenient time and travel. We have our electronic health records with our data collection and our personalized health notices to keep up. In the healthcare today, we know cost is a big problem, and access and quality. These problems are affected because people are having difficulty getting their health insurance, and the health goals are to get good care, good health, good high quality health care. And then our majority of cost for acute care and physician services is much less than our public health services. Drivers of high health care cost prescription drugs, technology, our aging baby boomers, and then we talk about our Affordable Care Act again in 2010, which has created more individuals to be able to provide that, but that is always in the works to be changed and updated. Know that we have two classes that we're working with. We have those private insurances, the private insurance companies, which take care of anyone. And then we have our public, which are those that are going to depend on our public funds. We have our Medicare and our Medicaid. Know that we have a strong relationship between health insurance coverage and access to health care, so that our Affordable Care Act, again, helped to get more insured. When we look at our quality of healthcare in the system, report noted that there's medical errors that occur. They could be prevented, but we're rushing to get things done. We're trying to keep people safe. And there's a report out, keeping people safe, transforming the work environment of nurses came out, and it reports that nurses' long hours pose a serious threat to our safety of our patients. So because fatigue will cause bad decision making. When we look at our organization, like I said, the healthcare system is divided into two. We have primary care and we have public health. Our primary care is delivered in community settings like physicians' offices, and then our public health is like immunization mandates that are required for kids across the board. Our public health system at the local level provides care to give us state and federal mandates. When we look at our federal mandates, we have the U.S. Department of Health and Human Services, and it's most heavily involved with the health and welfare of the United States. It has lots of programs to protect essential human services. Our U.S. Public Health Service is a major component as well. U.S. Department of Homeland Security is going to be keeping us safe against our terrorism and other acts. We have our community emergency response team, which trains people to be better prepared. That's going to be federally funded as well. We have our state health departments, which are going to be disease prevention, providing mental health. And then our local health departments are going to be working with our smaller subsets of our communities. Let's see, primary health care, we're going to just sort of look at this. Primary health care is broader than primary care. So, our setting for primary health care is for primary health care across the board, not just primary care. We look at our overview of global nursing. We have an International Council for Nurses. We have our Health for All 2021, which were our goals. We had goals to tackle determinants of health, use health outcome-driven programs, participate in health development, and look at our developing countries and what we know about that. When we take a look at our population health, we know that there are factors that are involved when we look at our determinants of health, and know that our determinants of health is going to be how are we going to have outcomes. So what is going to impact that? If we think about our income and social factors, we look at social support networks, we look at education, employment, working, physical, social, biological, personal health practices, coping, and we know we have seen that the lower the education, the lower the income, the poorer our health outcomes are. So these are some of our health determinants. We're going to promote health and prevent disease with our Healthy People 2030. What it does is it gives us a framework to have healthy outcomes. It builds on our accomplishments of the prior Healthy People 2020, and it helps us as nurses have data to show that it's helping. Healthcare reform, we've been talking about reform for a long time. American Nurses Association is looking to do something. Medicare was passed in 65, which helped those get some assistance if they were over the age of 65. Know that Medicaid is going to be for our low income or permanently disabled. Okay, so we take a look here at that. So that will cover our economic piece of healthcare for this week, and we're going to take a look at evidence-based practice as our last topic. So I'm going to share that with you. And we'll take a look at what evidence-based practice is. And this is how we practice as nurses. So our evidence-based practice means we have this conscious, judicious use of using best evidence in making decisions about certain individuals. So we do evidence-based medicine, public health, nursing, evidence-based practice as well. So when we take a look at our history of our evidence-based practice, often abbreviated EBP, we're going to have in the mid to late 70s, turning to the 90s, and then our current literature with our focus on applications in acute settings. We have our hierarchy of evidence, so blind, randomized, when we have different levels of studies that we can do that are going to look at our evidence. So our best one is our double-blind randomized controlled trials, where you're going to have randomized people selected in a trial. And so we look at our other ones. Non-randomized is not going to be as good. Quasi, case controlled, and qualitative studies are pretty good. So scientific literature found in systematic reviews is going to be one of our best types of evidence. We're going to have public health surveillance data. When we're implementing evidence-based practice, we need to know our previous evidence, philosophy of the practice environment, availability of our resources, links to outsource places, steps in our evidence-based practice. First, we have to create our question. We do our literature research. We look at our evidence. We find evidence and put that in with our clinical expertise and values. We evaluate our outcomes and then spread them around. So we look at finding evidence. We talked about this. Systematic reviews are going to be one of our best. This is meaning that they've looked at several studies and seen what they can find about a question. We also have our meta-analysis, which is in some systematic reviews, the results from studies are going to be mathematically combined and then found. So when we took at our evidence and when we're doing research and looking at how important it is, we want to look at our quality, our number of well-designed studies, and presence of findings in all the system. We have 3 domains: quality, quantity, and consistency. And we take a look at evaluating sample selection, randomization, blinding, sample size, outcomes, lengths of follow-up, things like that. Now, when we are implementing evidence-based practice, we may have some hesitation because people don't want to change. For example, if you've ever worked with a new computer system, a lot of people will hesitate in using that. So you want to really show them why this is the best thing. And remember, our evidence-based care, it's going to be to improve current outcomes. So we take a look at cost versus quality. We look at rising costs of healthcare, continued challenges. And with our Healthy People 2030 objectives, it provides general direction and focus for measuring progress of health status. We have some examples and interventions, which I'm going to skip, called the Minnesota model. So just know with our evidence-based practice, we're going to be doing whatever is best for our clients, and that is going to be what motivates us. Okay, so we covered 4 of our 5 chapters for this week, and the last chapter I will cover a little bit with week 2. Remember, this week you have your professional development paper due, and I will be posting this recording in our announcements. Thanks very much, and see you this week. Bye-bye.